Sleep apnea is becoming more and more common as the prevalence of obesity increases. An apneic event is defined as the cessation of breathing for at least 10 seconds during sleep. This leads to disrupted sleep and the classic presentation of daytime somnolence. When an apneic event occurs in obstructive sleep apnea, or OSA, which is the most common type, the respiratory efforts continue against airway obstruction. Here you can see that the airway is obstructed because of the tongue and the soft palate that close the airway. Because you have alveolar hypoventilation and hypoxia, you get secondary polycythemia from erythropoietin release in the kidneys, and pulmonary artery vasoconstriction in an attempt to shunt the blood with resulting pulmonary hypertension. So does this remind you of anything? It should make you think of COPD, where you see some of the same complications. You can also see right heart strain and the development of associated arrhythmias. So sudden death is a possible clinical presentation for patients with sleep apnea. In addition to daytime sleepiness, you get snoring and the patient's significant other witnessing the sleep apneas. These are the so-called 3 S's. When you see obese patients with daytime somnolence, you typically think of OSA, but these patients can have obesity hypoventilation syndrome separate from or in addition to OSA. This is also known as Pickwickian syndrome. How can you tell the difference? The arterial blood gas in a patient with OSA is usually normal. However, if you have obesity hypoventilation syndrome, you'll have daytime hypercapnia with a PaCO2 of greater than 45 millimeters of mercury. Central sleep apnea is less common and involves the absence of respiratory effort due to a failure of stimuli from brainstem command centers. You can see in this chart the lack of inspiratory effort during the apneic event. In other words, this is a neural issue and not a mechanical obstructive issue. What causes central sleep apnea? Well, things to keep in mind include narcotics, heart failure, renal failure, or a recent ascent to high altitudes. Obstructive sleep apnea is typically treated with weight loss, continuous positive airway pressure, or CPAP, or airway revision surgery. With central sleep apnea, you have to treat the underlying pathology, in addition to supportive care with CPAP. Let's do a flash quiz. What are the long-term sequelae of pulmonary hypertension? The answer is cor pulmonale and right ventricular failure. Step 1 respiratory case vignettes will often discuss lung physical exam findings. Here we'll try to identify the high-yield patterns that will help clue you into the diagnosis faster. Let's work through some scenarios together. If you hear decreased breath at one or both lung bases, especially with dullness to percussion and decreased fremitus, you might think pleural effusion. Remember, fremitus is a palpable vibration you feel with low-frequency vocalization. We'll talk more about pleural effusion later on. If you have a similar presentation but with tracheal deviation towards that affected side, you might suspect what condition? Atelectasis and bronchial obstruction, since you get tracheal deviation as the lung collapses distal to the obstruction. We'll talk more about pneumothorax soon, but this is a situation where you have a collapsed lung. This is really the only condition where you expect to see hyperresonance. See how the collapsed lung causes a hollow space in the chest cavity. In spontaneous pneumothorax, the trachea tends to deviate towards the side of the collapsed lung. With a tension pneumothorax, the tracheal deviation would be away from the side of the lesion because the trapped air on the side of the collapsed lung pushes the mediastinal structures, like the trachea, to the other side, as you can see here in this chest x-ray. Finally, if you have increased tactile fremitus, you should be suspicious of pneumonia, or another consolidating process. Do you see the right middle lobe pneumonia in this x-ray? What would you expect to hear when you listen to the lungs? Late inspiratory crackles or bronchial breath sounds. Let's move on to lung cancer. Lung cancer remains the leading cause of death among both men and women. Suffice it to say, this topic is very high yield for step 1, and you're going to want to put a big star by it. Lung cancer may clinically present with cough, hemoptysis, and so forth, or it may show up as an incidental finding on chest X-ray or a chest CT. Metastasis to the lung is the most common malignancy that you'll find in the lung, and will commonly present as multiple lesions. Mets are typically coming from primary tumors in the breast, colon, prostate, and bladder. On the other hand, when primary lung cancer metastasizes, it most frequently goes to the adrenals, the brain, the bone, and the liver. The complications and sequelae of lung cancer are pretty high yield, and the Sphere mnemonic does a pretty good job of summarizing them. They include superior vena cava syndrome, Pancoast tumor, Horner syndrome, endocrine, recurrent laryngeal symptoms, and effusions. Other than these conditions causing their own set of problems, why is it important to know these complications? It's important because they're often the first signs and symptoms of lung cancer. So if someone has ptosis, meiosis, and anhidrosis, as in Horner syndrome, and a cough, you may want to think about a lung mass. We'll talk more about these complications very soon. Okay, let's talk now about the different lung cancer types. As we go through the various lung cancers, keep in mind their typical location in the lung, whether or not they're associated with smoking, their associated symptoms, and histologic characteristics. Adenocarcinoma makes up about half of all primary lung cancers, so it's the most common one out there. It usually occurs in the periphery lung parenchyma, often at sites of prior injury or scarring. What mutations should you expect in this cancer? KRAS, EGFR, and ALK. If you examine the fingers, what might you find? Clubbing, also known as hypertrophic osteoarthropathy. The bronchoalveolar subtype is much less common and is not related to smoking, and it typically spreads along the alveolar walls, appearing as thickening of the walls. On the histology of adenocarcinoma, you'll notice the involvement of Clara cells and/or type 2 pneumocytes. Fortunately, if you catch this form of lung cancer early, it can be surgically resected. Let's do a flash quiz. On exam, what do bilateral dullness to percussion and decreased breath sounds bilaterally at the lung bases suggest? The answer is pleural effusion. Squamous cell carcinoma has been clearly linked to smoking. How does it present? As a centrally located hilar mass arising from the bronchus. Hypercalcemia of malignancy may be seen with squamous cell carcinoma due to the production of parathyroid hormone-related peptide. This is an endocrine manifestation from our mnemonic sphere. Recall from the endocrine and musculoskeletal chapters how PTH stimulates osteoclast activity, thus releasing calcium from bone. Histologically, you're looking for keratin pearls and intracellular bridges. Can you see them on this image? Here's a keratin pearl, and here are the prominent intracellular bridges, almost like tram tracks throughout the image. Of the common primary lung cancers, this would be one of the better ones to have because it's resectable and you can catch it early enough and it has a relatively good 5-year prognosis. On the other hand, small cell or oat cell carcinoma is extremely aggressive and poorly differentiated with a terrible prognosis. Small cell carcinoma is a centrally occurring lung cancer. It can produce excess ACTH or ADH and can cause different paraneoplastic syndromes. Again, this is the endocrine manifestation, or the endocrine complication, as seen from our sphere mnemonic. Think for a moment how these might show up clinically. With excess ACTH, you may have excessive cortisol release and a Cushing-type syndrome, while excessive ADH in the absence of normal stimuli, also known as the syndrome of inappropriate ADH, or SIADH, leads to what findings? It leads to fluid retention and hyponatremia. Do you remember the name of the syndrome associated with antibodies to presynaptic calcium channels? That's right, Lambert-Eaton syndrome, which you learned about in the musculoskeletal chapter. What is the hallmark presentation of Lambert-Eaton syndrome? The classic presentation is the patient with proximal muscle weakness. On histology, you'll note the chaotic or undifferentiated quality of this lung cancer. The small dark blue stained cells are the neuroendocrine Kolchitsky cells, which can lead to some of the paraneoplastic syndromes we just discussed. What genetic aberration might you expect in this situation? Amplification of the MYC oncogene. This type of cancer is not resectable. And why is that? It's because metastasis occurs very early on. It can be treated with chemotherapy, but as I mentioned, it has the worst 5-year prognosis among the major lung cancer types. Large cell carcinoma tends to be peripherally located. This type of lung cancer also has a very poor prognosis compared with other non-small cell lung cancers. It's not really responsive to chemotherapy, and resection only works about half the time. On histology, note the large undifferentiated cells and pleomorphic giant cells. Thus the name large cell. Carcinoid tumor is an interesting but uncommon lung cancer that carries a fairly good prognosis, which makes it perfect for step 1. This typically presents as a bronchial obstruction with coughing or hemoptysis. If you were to biopsy the mass, histologically you might see carcinoid cells in these classic rosette patterns, here and here. Occasionally, you can also see it present as the carcinoid syndrome, where you get flushing, diarrhea, wheezing, and salivation, all due to the tumor's production of serotonin. You can also get fibrosis of the tricuspid and pulmonary valves from high levels of serotonin, which can lead to right heart failure. So here's a board-related question. If you have someone who presents with carcinoid syndrome, where else would you look other than the lung? Well, carcinoid tumor more commonly occurs in the small bowel and the appendix. However, you usually don't see the carcinoid syndrome unless they're metastatic to the liver. Why do you suppose that is? Because the substances released by the carcinoid tumor in those locations are typically metabolized and inactivated by the liver. Okay, getting back to the lung. The good news is that this type of tumor tends to be slow growing and doesn't often metastasize. This is mainly treated by surgical resection, and the 5-year survival rate is really good, 75 to 95%, compared with the other lung cancers. Overall, how can you remember which of these lung cancers are central versus peripheral? One way to remember them is that all of the lung cancers with the S sound, squamous cell, small cell, are central. Next, mesothelioma is a disease of the pleura, although it has been diagnosed as a disease of the peritoneum. Do you recall the related exposure for mesothelioma? Asbestos. Of course, the risk is multiplied with cigarette smoking. It is characterized by pleural plaques, thickening, and effusions, and has a very high mortality rate. This is a chest x-ray of a 67-year-old man exposed to asbestos 40 years ago. What do you see? You can see large pleural-based masses in the right lower lung, with loss of right lung volume, likely due to scarring and atelectasis. This is a coronal reformat of a chest CT in a patient with left-sided mesothelioma. You can see the extensive pleural mass with contraction of the left hemithorax. On histology, you'll see stomoma bodies, which are laminated calcifications. These happen to be examples of stomoma bodies from meningioma, but they look very similar. Let's have a flash quiz. What do keratin pearls in a lung mass suggest? Squamous cell carcinoma. Pancoast tumor is a classic type of lung cancer situated in the apex of the lung. Here's an example of a Pancoast tumor that can be seen in the upper right lobe of this chest x-ray. These are typically non-small cell lung cancers. Why is that? As you might remember, small cell lung cancer tends to be centrally located. Remember this for central. You can get Horner syndrome through compression of the cervical sympathetic plexus. What structure is affected if you also get pain and weakness in the arm and hand? The brachial plexus. You can also get hoarseness if the right recurrent laryngeal nerve is involved. What other structure might be obstructed? The superior vena cava, which brings us to superior vena cava syndrome. We mentioned superior vena cava syndrome earlier as a potential complication of lung cancer and as part of the sphere mnemonic. You can see the lung cancer on this chest x-ray, which is compressing the SVC. So what would you expect to see because of this? Since you're blocking venous return from the upper part of the body, you can see facial swelling or plethora, as well as JVD and upper extremity swelling. You can also get shortness of breath, headache, dizziness, and rarely cerebral edema, aneurysm, or a brain bleed. Here's a picture of a patient with SVC syndrome. On the left, he has facial swelling in the early morning, which is resolved by the time the picture was taken on the right, later in the day. You can see the fullness of the face compared to what his face looks like at night. SVC syndrome mostly occurs in older folks secondary to bronchogenic carcinoma. If you saw this in younger folks, what would you think? You may think of lymphoma or leukemia or possibly something infectious like TB. Thrombosis can also be a cause secondary to any type of coagulopathy, or maybe a central venous foreign body like a catheter, pacemaker, or guide wire. This condition is obviously a medical emergency because it can increase intracranial pressure and possibly cause a brain bleed. Treatment choices include steroids, diuretics, endovascular shunt, as well as surgery, radiation, and chemotherapy directed toward the lesion.